Greetings and welcome to Flanigan's Ecologic. I am your host, Ted Flanigan. And today I've got Dr. Tyler Evans on the podcast. He's a physician and academic and author. He has led global health responses to Ebola and COVID-19. In 2021, he co-founded the Wellness Equity Alliance. He's now the CEO. It's a national public health organization that fosters a health equity at home and abroad. He is focused on health equity for marginalized populations worldwide. Dr. Evans, welcome to the podcast.
Thanks for having me, Ted.
Let's just jump right in. First off, are you based in Santa Cruz? Am I reading
Yes.
correctly?
Yes.
What a wonderful place to be. Super.
It doesn't suck.
It doesn't suck at all. Let's just jump right in. What is health equity?
I guess the best way to describe it is what it's not. It is not equality. So I like to kind of compare and contrast equity and equality. Essentially, equality is equal. Everybody is equal. Equity is different. We know that there are a number of people that are historically marginalized or vulnerable, and so we need to do better. We need to provide them with more equitable sort of opportunities from a health standpoint in order to access healthcare. At least a third of the country does not or will not engage in healthcare in the way that it's currently set up. There's good data for that. That data, unfortunately, was done kind of right before the pandemic. And so I believe that number is now significantly higher. So probably about half of the country cannot engage in healthcare in the way that it's intended to be. So what that means is we got a lot of work to do from a health equity standpoint in order to improve access and quality for a lot of Americans.
A lot of work to do, and we'll talk a lot about internationally. It's even more extreme.
That as well. Yeah, of course.
Right. And a lot of my listeners are familiar with energy equity, and I've had guests on the podcast talk about energy equity, basically access to even the most basic levels or the most subsistence levels of electricity and things like that.
I'll give you a great example. We were working on the southern border of Texas with the colonias, which most folks have not heard of. Why? Because many of them have been forgotten. There's almost 2 million people living in the colonias, and that's the southern border of the United States and Texas, particularly Texas, New Mexico, and California to some extent. And a lot of those folks are living on ranches, and they don't have access to energy. They don't have access to certainly healthcare, refrigeration, et cetera, et cetera. So during the pandemic, we were working with these folks and trying to engage them in healthcare, but energy was a major challenge. And again, these are Americans. These are not undocumented individuals. So.
Right. How'd you get into this? I was looking at your background. You studied at University of Southern California, your BS there in gerontology.
Yeah.
And / English literature. And I had to look up gerontology, the multidisciplinary study of biological, psychological, and social aspects of aging. So somehow you went from aging to tropical diseases to tell me how that progressed.
Sure. So my own personal journey, I like to sort of describe it as lived experience. I had a pretty rocky youth and adolescence. Lost my family at a young age. Prior to age 21, I was orphaned, and so I had to. And I had a lot of challenges. My mother suffered from mental health and substance use issues. So had a lot of challenges as a youth. I got my GED when I was 17 years old, and ended up going to community college. Had a child at a young age. Now she's getting her PhD. And so had a few things sort of thrown at me, and got into finally kind of woke up, understood the importance of education. Got into USC, and that was really a major eye opener for me, because I was now really provided with access to quality-based education. Networks were changing, et cetera. But what I was really compelled to do was work with other people that I understood. And those were people that were struggling. So I started working on the southern border of Mexico, around Tijuana, and in some of the low-income neighborhoods there and ghettos. And that was really with a few doctors out there. We used to go on the weekends, and that was really compelling. Then later on, late 90s, I was in Uganda and South Africa during the major sort of HIV. I mean, HIV is still in sort of pandemic phase, but this was a time where there was a lot of challenges because people didn't have access to the antiretrovirals. So this was when Mandela was still around, and the other leaders like Zaki Ahmed. I first had exposure to Doctors Without Borders, and I saw all these kids with that were infected with HIV. This was when mother-to-child transmission was still quite prevalent, and seeing these kids who probably would not get access to the medications because many of them were making less than $1 a day. Their families were making less than $1 a day. I saw that as a major social injustice, and so when I was from Mexico to Uganda to South Africa, that to me that was my light bulb moment. That's where I saw that I could really provide the privilege, that I had, which some of which was accidental, and empower these communities and really give them a voice. So that spark then continued to sort of illuminate over time. And as I worked in a number of other countries, Nepal, Haiti, Brazil, India, et cetera, my understanding of the sort of the inequities in the world further deepened, and further advanced my education and training, and sort of allowed that education and training to really kind of correlate with that original vision. So now it's evolved and deepened, and now I've sort of changed my my day-to-day work from kind of working with individuals to working with systems. I still see patients as well, but I often sort of view the system now as being sick. And so I turn, again, most of my attention to try to kind of addressing that so that we can really kind of impact the core components that are making these sort of systems and these communities sick.
Fantastic. Well, I was impressed by your educational path. I don't know where you've not gone to school. You mentioned a community college. You mentioned USC, NYU, Columbia, Tel Aviv University, SUNY Buffalo, London School of Hygiene and Tropical Medicine at the University of London. Did I cover the bases there? That's a lot of academics.
Yeah, I think that was all of them. University of Arizona as well. I lots of continents that I covered, and that really just helped me better understand, again, these other systems, these other healthcare systems, and the communities in which they are operating. Because my focus is, while I focus most of my attention right now on the U.S. issues, I really look at the world from a global standpoint.
Right. And you are an MD, right?
Yes.
So, like you said, you're still seeing patients with infectious diseases?
I'm my training is in adult infectious diseases and addiction medicine, but I also have 2 masters in public health and epidemiology. And
then are you still on the faculty? It sounds like you've been on the faculty at USC and University of California, or UC San Francisco?
I was at UCSF. I gave up that appointment a few years ago. Now I'm just at USC at Keck School of Medicine, Department of Population Public Health Sciences.
And so you come down to LA periodically?
Well, our operations in California are all in Southern California. So I come down every few weeks. So we run Wellness Equity Alliance, my organization. We run a number of operations, mostly around HIV street medicine. So we're in LA, Riverside County, San Bernardino, and San Diego.
And let's talk about the Wellness Equity Alliance. Is that you co-founded it in 2021?
Yep.
And what is its mission?
Sure. Its mission is really to kind of be a catalyst for system transformation between public health and healthcare to serve the most historically marginalized. There's some real fault lines between public health and healthcare in the United States. Some people think of them as synonymous, but they're definitely not. And we saw that during the pandemic, those fault lines were further sort of widened, and a lot of people fell through the cracks. And unfortunately, now under this administration, it's getting worse. Those sort of fault lines. But our organization, essentially tries to sort of fill in those gaps. to connect with these sort of different systems between, again, public health, hospital systems, federally qualified health centers or ambulatory healthcare, managed care plans, et cetera. So we try to be the connective tissue as much as possible. Concretely, if you think of us as a tree, the trunk of the tree is public health or public health equity, being sort of public health extenders. And then the branches are street medicine with a focus on HIV and substance use, rural health, tribal health, and behavioral health.
Mm. Does it all boil down to money, a lack of money, or is there more than that? I think you're going to say it's more than that.
It is more. I mean, it's a lot is connected to money. A lot is connected to money, but it's you can't just throw a lot of money at these issues and just expect it to resolve. But there is definitely some material impacts there. But I mean, it's really the application of money. It is the investment in the right sort of areas. It is the communication. It's also trust. Trust is a major issue. This is not an American issue. We're seeing this a lot in Democratic Republic of Congo with the Ebola outbreak right now. A lot of countries do not trust the government, do not trust the systems sort of around it. Right now, we're in this really odd sort of space in the United States where we're sort of questioning or opposing expert opinion, particularly around science. We have Dr. Fauci right now, who's on trial. This is a really dangerous space that we're in, where a lot of folks think that they know better than some of the sort of experts out there. And I'm not just talking about scientists. I'm talking about a lot of other spaces. People are in their echo chambers, and the reality is, experts are experts for a reason. And so that trust has really eroded. I live in the healthcare and science world, so I've been experiencing it. There was a Pew study that came out, I think it was in 2018, where it was identifying basically the trust that people had in certain professions. Number one was teachers. Number two were nurses. Number three were doctors. I think it was 16 or 17 were scientists. I don't know where that number is now. It's probably in the triple digits, unfortunately.
But you're saying that we trust our teachers, we trust our nurses, we trust our doctors.
We did. I think we still do for teachers, and I don't know about doctors and nurses. Love nurses. My other daughter, one's doing the PhD in social work. One's doing her doctorate of nurse practitioner. So she's a nurse right now. So I think we still love nurses. Don't know about doctors. Definitely don't think so about scientists.
Isn't it crazy now with the internet? I know that I've heard many cases that, people are looking up on the internet and they're sort of challenging their doctors, right? They feel like they can, individuals with no training at all can go on the internet and get information and then go back to their doctors and say, you're wrong about this or you're wrong about that.
And it really doesn't matter. It's interesting. I see all kinds of patients. Most of my patients are, more underserved communities. That's just, my preference. But from people from a doctorate level to, somebody without a high school diploma, I often am, I wouldn't say often, but not infrequently getting challenged for that. It's getting worse. I say, oh, well, I looked at this, and this is a challenge pre kind of social media and sort of Google, now AI. There was in the U.S. we have some real. I guess the best way to say is just sort of entitlement components. There's a lot of patients will come in. And I'm trained in, I'm a specialist, but I've been running primary care programs. I love primary care providers. I think some of the best doctors are family medicine doctors because they're kind of the jack of all trades. And so they'll come in and they'll say, oh, I've got this headache. I need to get a, referral to a neurologist, or, I've got this skin lesion. I need to go to dermatologist. They already have this plan in their minds that they're coming in and they're telling their PCP what they need. And empowerment for the patients is very important. Autonomy is very important, but it's a partnership, right? Like they're coming into the expert to unpack what they believe that they need, and then it's up to the expert to give them the guidance on what that is. But that eroded a long time ago, and so we really need to work on that partnership.
Yeah, I've heard that several times. I just went to my doctor to get a referral to the specialist. That's all. That's sort of the purpose of the visit, right? As opposed to take advantage of that doctor's expertise, that broad expertise.
And that leads to it's poor healthcare outcomes because you ultimately you got too many cooks in the kitchen, right? Which is never helpful because they're not talking to one another, and then it drives up expenses. I mean, in terms of specialist care, the United States is number one in terms of their expenses, and that's one of the major contributors to our outlandish expenditures for healthcare. I mean, we're number one in terms of healthcare expenditures. The closest country is Germany, and we spend 2.5 times more than they do in terms of percentage of GDP.
So one takeaway is take advantage of your primary care physician's expertise, right?
Absolutely.
Don't discount it. Don't readily discount it on this pathway to your vision of going to a specialist.
Primary care providers are so important, and they really, if we allowed them, all my PCPs that work for our organization, we really encourage them to work at the top of their license or their scope, and PCPs really can do, mental health, substance use, infectious disease management, quite a bit. In fact, I mean, this is sort of faded away, but a lot of them were trained in OB as well. Family medicine doctors were trained in OB. Yeah. We're still delivering, babies up until recently. Some still do. It's more of the old guard, unfortunately.
Yeah. So this topic seems so huge. I just don't know how you decide where to focus. Right? You talk about that. How have you decided where to focus?
That's a good question. I mean, there are so many challenges, both in public health and healthcare, that every day, it's like, what makes the most sense? So it's a great question.
Greatest impact. Yeah.
Correct. Yes. So I think the best way to answer that is, when you uncover all of it, right, you find these root causes, right? I wrote a book, Pandemics, Poverty, and Politics. And this was my sort of life's sort of a collection of my sort of thoughts of over the course of decades. And the reality is I spent, a number of years in sub-Saharan Africa, the Middle East, South Asia. And I was the only doctor in South Sudan for 29,000 refugees or internally displaced people. I've worked in war zones, complex humanitarian emergencies, and then I've worked with Native Americans on the Wind River Reservation in Wyoming, where the mean survival was 53. I've worked in the South Bronx, where there was, which has the worst health indicators in the entire state of New York. I've worked in South LA. I still work in South LA. I have a theory about the South, but the reality is, while the scales of the magnitude of burden of disease could be considerably different between these different sort of areas, the contributors are very much the same, right? There's a common thread throughout all this. And in my book, I basically outline historically all of the major pandemics or public health emergencies of international concern that have taken place since the beginning of the 19th century until today. And I give the reader a rubric of the social and political determinants. And I give them an opportunity to basically kind of grade the social and political contributors to each of those pandemics. And ultimately at the end, the objective is to, through sort of self-realization, understand that there's a common thread throughout all of these. And until we address that common thread, we're going to continue to see more of the same. So in terms of your question, I focus on the common thread, right? That's the root core component of all of these pieces. That's why I described the tree, because the trunk of the tree is that common sort of factor where I spend most of my time thinking about.
Mm-hmm. How interesting. And that book just came out in what year? Was that 2 or 3 years ago?
No, just last year. August. I should know this was my son's birthday, August 5th. So almost a year.
That's my daughter's birthday. Okay, very good. Well, are most of the major issues that we're facing now related to climate change, or
a lot of it is, yeah. I mean, from an infectious disease standpoint, we've got some real, ecological contributors for sure, which again leads to some of these social and political inequities as well. Of course, when we're looking at Europe right now, that is dealing with record-breaking heat temperatures. And the fires, as the result of a lot of these other pieces, a lot of folks are dying. I mean, the number of excess deaths is unprecedented this summer in France and Spain. And so, and we're going to see the emergence of infectious diseases as a result of that. When we are living in this world, we're sharing this world with all of the, a lot of the kaleidoscope of bugs. Right. When we look at microbes, the best way to sort of organize them is into 5 different buckets. You got bacteria, viruses, fungi, parasites, and worms or helminths. And we have to live in balance with them. And the more that we are impacting this climate, the more those bugs are getting irritated. And there's this ongoing emergence of emerging communicable diseases and or prior infectious diseases that were controlled and now are becoming uncontrolled. And so part of that is through political changes. Right now we're seeing unprecedented measles outbreaks. We're seeing a number of outbreaks of Legionnaires
well, I wanted to, if I could interrupt you, I wanted to talk to you about the Legionella bacteria, because
sure.
You had said that the hotter the temperatures become, the more you got these building cooling systems or cooling towers. The bacteria are getting into those cooling towers and magnifying, and the problem is just getting worse and worse. So, how do we address that issue right there? I mean, that extreme heat is a effect of climate change, but it's resulting in a very specific bacteria multiplying. Is that it? Can we focus on that one issue
absolutely.
for a second?
Yeah, absolutely. Yeah. So Legionella is, and I mean, we could also talk about cyclosporiasis as well, because they're very much sort of share a common component, which is heat. During the hotter months, cyclosporiasis. I'll start with cyclosporiasis. Is not new to us. We have seen outbreaks take place on a relatively frequent basis. It happens every few years or so, and so this is something that we expect. We almost always see these outbreaks taking place between the summer months, between May and August.
Yeah.
This year, this is unprecedented. I mean, we're getting. I just checked last night. The numbers were over 18,000. This is unprecedented. Just for historical reference, the largest outbreak on record was 2013, which was around 800 cases. So now we're getting north of 20,000 cases.
We're talking about, is that in the United States or where
in the United States?
In the United States, okay.
In the U.S. Yeah, and now it's almost every state, 45 states that are currently experiencing outbreaks. Curiously, California has not yet had that, and there's a few reasons for that. But so this is heat. This is correlated with heat. This is how the parasite really thrives. The parasite will probably, this too will pass as the summer cools off. But it's partly, there was the Taylor Farms sort of accelerator that most folks are aware of through Taco Bell. There were 4 other contributors to it that really made it a perfect storm. But heat really was an accelerator of that. Legionella, same thing. Legionella really thrives during the hotter months, and it's vaporized essentially through these it stays in these water cooler towers and whatnot, and then it's vaporized into air conditioning systems and whatnot. People use more air conditioning obviously during the hotter months, so there's a higher risk of that sort of diffuse vaporization taking place. For Legionella, it's really the older adults that are mostly at risk. We could, if healthy adults with their immunities intact, if they are exposed, many of them may be asymptomatic, may not even experience any respiratory or pulmonary issues. But it's really the older adults who, again, they're the ones who are spending more time indoors. Right. They're the ones who probably have more air conditioning. And those are the ones also who are more at risk of dehydration. Getting over to cyclosporiasis, that's a real, there's also older adults are more at risk, and people with impaired immunity. Cyclosporiasis was famously correlated with HIV. I'm an HIV doctor, and we saw this quite a bit in the 90s and early 2000s. We still see it in the global south. And you would see wasting, so severe loss of weight, in advanced HIV, otherwise referred to or previously referred to as AIDS. And dehydration. So dehydration is very, very serious, particularly during the summer months. Older adults or people with impaired immunity will be at higher risk of dehydration in general. So if you have the summer with general heat and impacting dehydration, and then you add in the bug, it just kind of doubles. It's just sort of adding insult to injury. So that's something also to be concerned about.
So are you have lots of friends that are working on climate issues, and some people are completely focused on adaptation. I'm guessing that that's pretty much the way you are. You haven't devoted your career to trying to reverse the ravages of climate change. I don't believe, but you're really helping people that are dealing with it, helping them to adapt to it. Is that right?
Absolutely. Yeah.
Okay. So we have I think a very regressive situation that the sort of the lower income people are living in the worst housing, the oldest housing. Talk a little bit about that and how we can address that as a society.
Sure. So Legionella is a perfect example. I address some of these in my book, Pandemics, Poverty, Politics. Legionella is almost invariably taking place among Black and Brown communities in New York. I mean, it's in other cities as well, but I was the chief medical officer for New York City. I'm from New York, so I'm very closely connected to it. There's a current outbreak taking place right now, as we were discussing. But it's curious because this outbreak is very unique. It's in the Upper East Side, which is some of the wealthiest, most privileged communities in the country, if not the world. But almost invariably, prior to that, it's in Black and Brown communities, particularly Harlem and the Bronx. And part of that reason is structural. When it comes to the social determinants of health, this is one of those determinants. There are structural inequities. A lot of buildings were historically redlined, et cetera. And so some of these buildings were not basically up to code. The cooling towers are older, et cetera. And then a lot of these, to add insult to injury, a lot of these folks are not connected to healthcare in a meaningful way as well. So that makes the outcomes that much more challenging. That's just New York. Zooming out further, when we're looking at migrant populations, climate change is one of the most formidable contributors to migrant populations. We're dealing with something called climate refugees. This is a serious issue for populations across the world, and they're going to be at risk again of those infectious diseases because they're in these migratory sort of patterns. They don't have access to healthcare, preventive health, preventive measures. Their immunities are going to be further impacted. And in my book, I talk about something called population stress. So the best way to think about it is looking at the herpes virus. The herpes virus goes through something called the lytic cycle. And so it is activated. It's basically constantly sort of circulating, and it's sort of activated during times of stress. That can be either emotional or physical stress. So it could be like a cold, and people will manifest a blister. They call it a cold sore. The reality is it's herpes. Close to 90% of people have it. And so that's on an individual level, right? On a larger scale level, when you have certain viruses that circle around populations, Ebola is a perfect example. And it's living in certain reservoirs. I also talk about HIV also being activated. And then you put stressors in there: war, poverty, migration, all of these components. You put those in there, and it creates that stress from a scaled standpoint. It creates that stress, that sort of perfect storm, almost like a pressure cooker scenario, where these viruses then sort of emerge because people's immunity is impacted, right? Because because they're poor, they're embattled, they're dealing with significant struggles, food insecurities, et cetera, et cetera. So that leads to a higher risk of infectious disease transmission, which then leads to epidemics, to possibly pandemics.
What would you like our listeners to take away from this discussion? I mean, it's sobering, frankly. I mean,
right.
So what can we do? What can we do?
So the good news is I'm a hardwired optimist. So I know that a lot of the discussion we just had sounds very dystopian. But the reality is, I think that we have an opportunity for the pendulum to swing back. We're dealing with some pretty significant challenges, not just in the United States, across the world, in terms of trust, in terms of inequities, really, really poor leadership in a lot of nations. We've got a number of active wars, et cetera. But I think that these, and history has demonstrated that this active sort of pendulum that has swung so far in the opposite direction will swing back in a more favorable direction as we kind of, reel from these losses and understand basically how to rebuild. And so I think as this country, United States, and other countries will sort of comes out of this, we'll find opportunities to work more effectively, both within and with one another, because we can't do this all alone. I mean, we're talking about environmental components. We're talking about infectious diseases. Yeah. There are no borders that can sort of control these scenarios, right? We're all connected. And if we don't acknowledge that, then we're just not acknowledging reality. So my hope is that, we will, again, kind of take some of these experiences, these unprecedented outbreaks, these unprecedented temperatures, et cetera, take some of these opportunities to go back to the drawing board and to make this a healthier and more stronger Earth.
Yeah. Oh, great. I'm glad we ended with your hardwired optimism and the pendulum swinging back. And how does this hardwired optimist, Dr. Tyler Evans, how do you maintain balance in your life? You're working in some of the toughest situations that anybody could ever ask to work in. You look like you're healthy and thriving. How do you do it?
Sure. I balance. I mean, I work hard and I play hard. I have my family, love my family. I've got 4 kids, 2 little babies. I got a 4 and 5-year-old. He'll be 6 in a few days. And they're my everything. So that's incredibly important. We have fun. We're, during the summer, we've been, creeping into a few different travels here and there, a little camping, saw some World Cup games. So that's been good as well. I'm very active in terms of, my own health and wellness. I exercise almost daily, and read. So there's a healthy balance. And I think my wife might have a different opinion of whether or not I strike a healthy balance. But
what balance?
Yeah, right. Yeah.
Hey, listen, thanks for being on the podcast.
Thanks for having me, Ted.
That's it. Thanks for listening to Flanigan's EcoLogic. We'll see you next time.